Understanding the Colorado End-of-Life Options Act, and TRU's position of engaged neutrality. There are few arguments in healthcare that are as divisive as whether or not people should have the right to die when they choose to with the use of medical aid in dying. The arguments for or against Colorado's End-of-Life Options Act, referred to here as the ELOA, are ideological, based on many important aspects of our society: the law, religion, spiritual beliefs and practices, ethics, and social mores. Opinions vary based on personal experiences, belief systems, age, culture, and other aspects that influence how one thinks about life and death. The ELOA can be very emotional on both sides of the issue, for those who support and those who oppose medical aid in dying. TRU believes in a healthy discussion and honors staff concerns regarding the ELOA, but also understands that medical aid in dying, as defined in the Act, is a legal option for patients in Colorado. It's important that individual participants review two important documents prior to participating in this training and know that these documents are available for you as a continuing resource. TRU's Colorado End-of-Life Options Act Talking Points and TRU's Colorado End-of-Life Options Frequently Asked Questions. This educational program was developed by the Ethics Committee of TRU Community Care to help staff understand the organization's position related to the Colorado End-of-Life Options Act, or ELOA, which allows for terminally ill patients to access medications to facilitate medical aid in dying. TRU's position of engaged neutrality was brought about from concerns raised by patients, families, and staff members about the ELOA. The Ethics Committee provided the organization's response within an ethical framework that allows for respect for patient autonomy, providing care that best supports each patient's goals, promoting patient well-being, doing good and reducing harm with an understanding that not all symptoms are easily managed, support for TRU's commitment to fidelity, that is, keeping promises, and non-abandonment in providing care for all patients and their families, and holding on to the values of justice and fairness by making sure that all patients have access to all available legal options. TRU's clinical mission is affirming life at every step of your journey with illness and loss. To accomplish our mission, we must focus on relieving anxiety and distress, honoring choices that patients make, and training and supporting our staff to journey with all of our families no matter which legal options they may choose. In revising TRU's policy, the organization's board of directors felt very strongly that staff be allowed to have a conscientious objection if individuals have a personal desire to not be involved. It is important for TRU to honor staff's personal beliefs, to ensure that all staff are able to provide information about the ELOA in a non-judgmental way, with an understanding that clarification, education, and experience for staff can relieve many fears. The goal of this ELOA training are to have a better understanding of the Colorado End-of-Life Options Act and how it's working, to have a better understanding of TRU's policy related to ELOA and medical aid in dying, often referred to as MAID, and how all of this fits into TRU's mission and vision, and to help TRU's staff feel confident, empowered, and skilled about the ELOA to support patients and their families wholeheartedly while respecting individuals' beliefs and values. In order for TRU to fulfill its mission of leading a healthcare transformation, the organization must be willing to engage with the larger community around changes that impact the way healthcare is delivered. This is certainly true for the ELOA and MAID. The ELOA has both eligibility and qualification requirements. As defined in the ELOA, to be eligible, an individual must be terminally ill and have a prognosis of 6 months or less, be a resident of Colorado, be an adult, that is over 18, have decisional capacity, and be capable of self-administering and ingesting the medications. To qualify as defined in the ELOA, an individual must make 3 requests separately of the attending physician, 2 written and 1 oral. A second request must be at least 15 days after that first. And a second, called a consulting physician, must confirm the 6-month life expectancy, ability to self-administer, informed consent, and capacity, or document referral for future evaluation. If there's any doubt about decisional capacity, the attending and consulting physicians must refer the patient for a psych evaluation. In the 2 years since the ELOA was approved in a voter referendum, clarification has been gained in understanding the law and its use. Persons qualifying under the ELOA do not need to tell anyone they have become qualified. Often the use of the ELOA is more about psychological insurance, with 30 to 65% of patients who qualify for MAID ending up not taking the medications. No clinicians can be forced to participate. Many concerns raised during the debate about the ELOA, such as that allowing patients to choose death would result in a slippery slope, leading to abuse of the system and legalized murder, have not been substantiated in the years since the ELOA became law. Medications continue to change and become more sophisticated in an effort to bring about, in the words of the ELOA, death in a peaceful manner. As mentioned, medications used in MAID are changing. Secobarbital was initially the drug of choice, but due to extraordinary increases in the price of the drug, over 1,000%, and lack of availability of the drug, physicians and pharmacists are looking for new drug cocktails that lower the cost and decrease the time to death, improve taste, and avoid negative or allergic reactions for patients who use MAID. In many cases, anti-nausea meds are being prescribed to be taken in advance to help the patient when ingesting the cocktail medications. When patients receive the medications, they're provided with strict instructions on how to take them, including eat a non-fatty meal 4 to 6 hours prior to ingesting the cocktail, fat-free liquids as desired, stop all medication except pain and comfort pills 12 hours prior. A 1/4 cup strong liquor may be drunk or mixed in cocktail to enhance medication. Keep patient in upright position for at least 20 minutes. It's important for the patient to work closely with the pharmacist when filling the medication prescription to better understand how the medications are to be administered and what to expect when taking the drugs. The Colorado End-of-Life Options Act does not have robust reporting requirements. Physicians are required to report when a prescription is written for MAID medications, and pharmacies are required to report when the prescription is filled, but there is no requirement to report when a death is directly related to taking the medications. In the 2 years of data collection since the law came into effect, 12/2016, acceptance in the medical community has been increasing. In 2018, 125 patients were qualified to request the prescriptions, up from 69 in 2017. 66 physicians across Colorado wrote the prescriptions, up from 37, and 23 pharmacists dispensed the medications, up from 19. Barriers have been identified to the process as well, including patients and families who are eligible for MAID don't understand the process to qualify and may wait too long to meet the 15-day separation between the first and second oral request. Patients have reported difficulty finding attending and consulting physicians and pharmacies willing to prescribe and fill MAID prescriptions. Physicians and other medical personnel opposed to or reluctant to be involved in the ELOA, and physicians blocked because of organizational directives that don't allow staff to participate in the ELOA for various reasons. The ELOA can create complexities for patients, families, and clinicians, moral and ethical complications, understanding who are the appropriate clinicians to facilitate MAID and other end-of-life issues, the challenge of sorting out whether patient abandonment results from helping or refusing to help with MAID. How does MAID differ from suicide? According to the American Association of Suicidology, MAID is not suicide. Rather, it's a rational option for some people with terminal illness and facing imminent death to avoid the worst suffering at the very end of life. Is the law fair, inclusive, too loose or too constricting? What about people who cannot afford to pay privately for MAID medications, as most Medicare and Medicare Advantage plans do not cover the physician visit and prescriptions? What about individuals with diagnoses that would prevent a determination of decisional capacity, or those without the ability to self-administer, such as patients with Alzheimer's, ALS, or other physically limiting disease processes? Is there sufficient data collection to make a better law for more people? Where is hospice in all this? Although hospice programs are seen as the end-of-life experts in caring for individuals with life-threatening illnesses, funding prohibitions in federal law have caused hospices to stay away from medical aid in dying, which otherwise is lawful now under Colorado's EOLA. We do know that almost all individuals in the state who access MAID medications are on hospice care. Federal regulations prohibit the use of Medicare and Medicaid funds from being used, quote, for the purpose of causing or for the purpose of assisting in causing the death of any individual, close quote. Over 90% of TRU's funding comes from Medicare and Medicaid programs, so the organization is trying to balance the federal prohibitions and the states allowing for MAID. End-of-life controversies have evolved over time. The advent of hospice in and of itself was controversial to the mainstream medical community. Hospice was seen as a place where people would go when there was nothing further that could be done to cure the disease. In the early years, many people perceived hospice as using morphine to hasten a patient's death. Voluntary stopping of eating and drinking, VSED, a way for patients to take control by refusing all food and liquids, including those taken through feeding tubes, was seen as an inappropriate way to hasten an individual's death. For a long time, hospices refused patients with CPR directives, as this was seen as not being on the same page with hospice care. Disconnecting pacemakers or defibrillators was seen as controversial. Now it's an accepted practice as a way for patients to gain control. Even what we now know as palliative sedation has transitioned over time from being called terminal sedation and later total sedation. Again, a practice that was considered wrong or radical when first used that has now moved into accepted care. Even medical aid in dying has moved from being called assisted suicide, physician-assisted dying, physician aid in dying, to the current medical aid in dying. Again, giving more patients control at the end of life. Currently, 9 states and the District of Columbia allow for MAID. Patients may ask about MAID for many reasons: fear of future suffering, asserting their autonomy, testing the waters, psychological insurance, in pain or distress, need to discuss their life, ready to die. Regardless of the reason, TRU staff members should inquire what is behind the request and develop a care plan to address the patient's concerns. Meeting patient needs and addressing concerns proactively can alleviate distress. Regardless of one's personal feelings around MAID, healthcare professionals must balance their personal morality and professional ethics. Medical professionals cannot put their own interests or values above patient care. As well, personal priorities cannot compromise the equitable delivery of services. Medical professionals must be able to distinguish between distress and moral distress. Distress is how one may feel in relation to a situation. Moral distress is something that goes against an individual's core values. Moral distress or moral issues challenge our sense of ethics, standards of practice, personal value systems, sense of what we're doing is right, worldview of good and bad. As healthcare professionals, we always have to work to keep our professional and personal values in balance in an effort to provide the best care to our patients. In order for TRU's staff to maintain the professional and personal balance, TRU's ELOA policy allows for conscientious objection. The policy allows for an exemption of individuals who object to participating in the care of a patient who expresses intent to choose the ELOA. When a patient is merely asking questions about MAID, staff are expected to help the patient family to understand the requirements of the ELOA in a professional, non-biased manner. However, once a patient decides to pursue the use of aid and a staff member has a conscientious objection, this staff member has the right to remove him or herself from the care team when there are other options for staff assignment. It is always best for IDT members to work and coordinate together to address the needs of the patient. Whenever patients are discussing their end-of-life options, it's important for staff to develop an authentic connection based on a level of inquiry that allows a better understanding of what each patient needs. Thank you for trusting me. Tell me more about what you need. I'll help you until this is resolved. In each of these statements, we seek to gain trust and to help individuals to understand that their needs are important to us. TRU's position around the ELOA is neutral, neither for nor against, but rather engaged neutrality. Our responses to patients asking about MAID focus on what we can do to help them understand the ELOA and what TRU can do. Make sure we've helped in every possible way we can. Help brainstorm with the patient as the patient seeks to find resources. And communicate with the patient's attending physician. TRU staff members will provide our regular care during your journey with us. Be in the house with you when you take the medication, but not in the room. Support your family with emotional support. Provide your family with bereavement follow-up. It's important to ask the patient, how can we best support you? When discussing the ELOA or MAID, always seek to build an authentic connection. Respond to questions. I understand your interest or concern or questions. I'm glad you're bringing it up or asking questions. Tell me a little bit more about that. I hear you saying, reflect back what they said to you. I would like to help you by getting a team member who can explain more. Is there anything else I can do to help you right now? If asked by a patient whether you can be present when MAID medications are taken, and you do not have a conscientious objection, your answers could include these concepts. Your care is the most important thing to me. Always validate the importance of the individual's care. I will be honored to be with you during that part of your journey. What this means is that I can be in the house with you, but for our hospice to work within the law, I cannot be in the same room as you while you prepare and take the medications. I'll work with your team members to help you make the best arrangements to help this go well. If asked by a patient if you can be present, but you do have conscientious objections to participating with MAID, your care is the most important thing to me. Again, Always validate the importance of the individual's care. While I can't personally help you, I'll do everything I can to make sure that you get the best care we can offer. I will work with and support the team that will be supporting you. If asked, why won't you participate? My personal or spiritual beliefs don't allow me to participate in this, and I need to honor my tradition or long-standing convictions or beliefs. Because of federal prohibitions against using Medicare or Medicaid dollars for the purpose of MAID, TRU physicians are able to discuss MAID with the patient in terms of what it is and how it fits in with the patient's goals of care, but cannot serve in the role of attending or consulting physicians. Questions 9 through 14 on TRU's Colorado End-of-Life Options Act Frequently Asked Questions document that is part of this training assists staff in brainstorming with the patient family to help patients find the necessary resources, such as attending or consulting physicians, a local pharmacy to fill MAID prescriptions, etc. TRU continues to remain committed to excellent patient care based on the plan of care created by patients and their team, unconditionally supporting staff to balance their moral issues and their professional ethics, continuing development of policies that reflect the ethics, mission, and vision of TRU, encouraging all voices to be part of the ongoing dialogue. TRU wants to serve all of our patients and their families to the very best of our ability. Together as a team, we'll be able to move forward with our vision for the future of how we care for everyone in our community, honoring their choices and respecting their wishes.